Please.
Liam Woods, Director of Acute Hospitals.
Siobhan Cadelli, National Clinical Lead, Older Persons.
Anne O'Connor, Chief Operations Officer for the HSE.
And Paul Reid, CEO at HSE.
And I'm Paul Connors, National Director of Communications for the HSE. And also today, as usual, we have Michael and Lisa, who are our Irish Sign Language interpreters, and a very important service they provide for us and have done for the last number of weeks, and thanks to them. I'd also like to thank UCD for hosting us again here today. I just think the venue is very suitable for what we're trying to do here, particularly with physical and social distancing. We have the space here, and it's a nice bright location, so thanks to UCD for that. Our format today, we've got two speakers from our panellists. Firstly, Paul will give a strategic overview with a particular focus on testing and how testing has scaled up over the last week. And then we'll give an operational update, and with a particular focus on nursing homes and mentioning PPE. We'll then go into a question and answers session. So we'll start with Paul. Thank you very much.
Thank you, Paul, and good morning, everybody. I just wanted to, as Paul mentioned this morning, take a little bit of a step back, and we'll continue to give you some detail of our operational scale-up, but I wanted to just step back and set out a little bit of context about some of the strategic challenges that we face as we look forward, because as we look at the experience across many of the countries who've experienced COVID so far, and as we look at the modelling prepared by NEFIT overall, Professor Philip Nolan and his team. And as you look through that, it's very clear that COVID-19 is going to be with the Irish health system for quite a longer period of time than we may have expected. So my belief, we now need to look at the delivery of healthcare in Ireland in the coming couple of years through a very new lens, a very different lens, and we're going to have to organise very differently than we may have thought. It's going to fundamentally challenge how we do our assumptions about how we're delivering services in the HSE. And we're going to have to do that through what I would call a dual strategy. First of all, we're going to have to continue for a long period of time our responses, our models, in response to COVID-19 all across our system, whether that's our acute hospitals, our primary care, community care, social care, nursing home sectors. And that's a model that's going to have to stay with us. It's also going to be a model that we'll have to scale up and scale down, depending on how the disease behaves in the coming months and coming year. So it's going to be a model that's responsive, but it equally has to be a model that we can scale up and scale down as appropriate. The second way we'll have to look at delivery of our health services, how we need to continue to ensure that people use our health services for non-COVID related services that we provide. Thankfully, we're beginning to see people using those services, not just for time-dependent surgery, but for the wide range of services that we provide, whether it's in our hospitals, our communities, areas. But we're going to have to provide those services now in a very different way. So we'll have to have in our hospital system one which is very focused on protecting the public and our patients and our staff in terms of COVID, but equally one that delivers the other services in a very new way, because we're going to have social distancing with us, and we're going to have the relevant protections that go with delivering the other services as well. In relation to COVID-19, many of our initiatives and processes that we put in place were put in place for a period of 3 to 6 month period. We now know it'll be a much longer period of time. It'll be a period stretching well into 2020 and most likely into 2021. So the reality is now we need to build for a longer term model, not just a wartime response to COVID-19, to protect everybody. When we reflect on our responses to COVID-19 and just look forward to some of them that we may need and will need for the future, there are many new ways and new initiatives we've put in place, and the public will have experienced our services in very different ways during the last 8 or 9 weeks as in relation to COVID. And just to relay a few of them, our call centres, we put in place 7 call centres all across the country where the public can contact us with their concerns about how they're feeling, particularly in relation to COVID. They're working over GPs. GPs have very much become part of an integrated healthcare family, working very closely with the HSE, and I'd like to thank the GPs for their work with us through this process, for their support, for their leadership, and also thank the ICGP as well for the supports they've provided us. But it's a very new way of working for the Irish Health Service and indeed for the HSE. Our National Ambulance Service, traditionally an emergency response crews, now working very proactively at the early stages in the first couple of weeks, visiting people in their homes, now on a mass scale, testing all across long-term care settings and indeed nursing homes. A very new service provided by our National Ambulance Service, testing centres, never existed before, 47 of them now all across the country. How will we use those testing centres for the future? They will be with us. Clinical assessment hubs, and my colleague Anna Connor will set out the detail of clinical assessment hubs with multidisciplinary teams now in place all across the country. A very different way for the public to experience our services. And our critical care teams in our acute hospitals, putting in place new surge plans and new surge capacity, going well beyond our normal surge and ICU capacity and utilising high dependency unit beds and other, providing a greater level of surge in our hospital settings. The supports that we put in place for vulnerable groups, working together with agencies, NGOs, Section 39 organisations and the HSE, working in a very new way. And the flexibility of our workforce has been fantastic. I want to thank all of our workforce. I want to thank the representative bodies and the trade unions who've worked with us, broke down walls, didn't go through levels of bureaucracy that we might normally do, and put in place a whole new sets of workforce and practices. So there are aspects that I believe we have in place now that will need to be retained and put in place for the coming couple of years. There are other aspects which are policy matters which we need to look forward to in the future, which is what are the roles in the future of the public and private health systems and how do they work together. We know in the coming months we have secured the private health hospital groups working as part of a public system. What does that look like in the future? And indeed the role of private nursing homes and how they work, the role of the HSE, who's responsible for what. I really look forward for the future. And when we look back over the last few weeks, much of the firefighting responses we've had to put in place now need a much more strategic approach. And to quote two of them that we've updated you here regularly on every week, in relation to our PPE and in relation to our testing and tracing, we now need to look forward in a very different way, knowing that COVID is going to continue to be with us. So our strategy for procurement has now to involve building a stronger indigenous supply model. This obviously will have to operate within EU procurement rules and guidelines. But if you look at what we've had to do, and we still have to do right now in terms of the provision of PPE, because of the volume that we needed, because of the worldwide demand on PPE, we've had to source mainly overseas, large scale, the volume that we require. Just to provide a little bit of context on that, and I set out to you over many weeks, our provision of PPE normally for a year would have been 15 million. We put in place an order from China of 208 million. We're probably going to double that order again, another 150 to 200 million PPE, based on definition changes to masks and other demands that's coming on us for provision of PPE. And I say all of that because this is a model we're going to have to build Indigenous Irish, support Indigenous Irish industry, and there is an opportunity to help stimulate the economy, to help Irish Indigenous industry supply many of our PPE needs over the course of the couple of years, not just in weeks and months. And there have been many good examples of SMEs who put on the green jersey and redesigned their business models to supply us with much needed protection. And I'd like to thank them for that. So our plan looking forward on PPE will be twofold. First of all, get us to a sustainable model that we have sufficient supplies to protect and give us reasonable levels of comfort on our distribution. But secondly, to build a self-sufficiency model in the Irish market to provide us with a relevant and continuous supply of PPE. The issue of testing and tracing has been very prominent with us over the past few weeks. We've developed higher volumes and faster turnaround times. We now need to do that on a much more scaled up model. But we also need to develop a model that's equally sustainable for our future. Because we know, in terms of pandemics, we need to have a stronger capacity to respond for the future. That's our learning already. But in a short period of weeks, just to put it in context, we've put in place call centres all across the country where people can contact us with their concerns, new processes and agreements in relation to with GPs to support testing and tracing, 47 testing centres all across the country, and 27 labs now carrying out testing for us. We've demonstrated on one day a capacity to deliver 10,000 lab results, and we continuously scaled up our testing and tracing throughout that process. I'm pleased to say, over the work over the last few weeks, and particularly the intense work over the last week, we have developed a model which will bring us over the next few weeks to be in a position to scale up to deliver over 100,000 tests per week. This has been agreed, formally agreed, with the senior officials, the Secretary General and myself, Secretary General of the Department of Health, and it sets out a map over the coming weeks to get us to that capacity level. However, we also do need to develop a model for the future, because the model that we have put in place has been, as it is described a few times, a kind of war zone model. We've put all the elements together. We're going to maximise its efficiency and we're going to increase its volume. But looking forward to the future for the next 2, 3, 5 years, we're going to have to build a new model. It's going to have to be a national infrastructure driven by the HSE and run by the HSE, but we need a new model that supports the country in the future in terms of pandemics. And that will mean a much more integrated lab oversight, a much more sustainable process around contact tracing. So we will max out our current model and we will equally scope out a new model for the future. I'd like to also just recognise, as we look ahead, the flexibility and response provided by our workforce, and that too will have to be part of our new ways of working in the next couple of years. We're going to have to look at all our resources, which we did do during the last few weeks, and how are we ensuring that all of our resources are primarily focused towards our frontline services, because that's what we're here for. We're going to have to continuously break down barriers like we did in the future. We're going to have to break down levels of bureaucracy that make and enable the workforce, because we've seen, and I've seen, the response of the workforce. They are very focused on patients, they're very focused on the public, and if their true potential continues to be unlocked, we will have a much better health service. So finally, I just want to say my closing messages this morning are, firstly, we're going to have to look through a very new lens for the future for our health services. And I'm not talking about 10 years out, I'm talking about this year and the following year, because we know COVID-19 is going to continuously be with us. It's going to have to be a dual strategy, which has a key focus on protection of our patients and the public and staff on COVID-19 related issues, and has processes in place to enable all of our other services be delivered in a very new way. It'll also involve developing very new and sustainable models for supply of PPE and very new models for testing and tracing in the future. But from my perspective, we can't go back to traditional models and practices. This is a new vision, this is a new future, this is a new lens we're going to look through in the future. We're also going to need to retain and sustain some elements that we've put in place in the past, some elements that would have been identified in Sláinte Care that we have put in place. And equally, we're going to have to be open to challenge some other elements of Sláinte Care for the future that now need to be retested and now need to be re-looked at for our future coming years in the HSE. Thank you. I pass you to my colleague, Anne O'Connor.
Good morning, everyone. I'm going to talk through the activity that's happening across our system, both in our acute and community services, and just some other key areas of interest around nursing homes. So just to kick off, in terms of the activity that we're seeing in our acute hospitals for the past week, we can see that there has been an increase in attendances at our emergency departments. So we went up in the past week by 10.3% to 16,566 attendances. Now that is still over 33% lower than last year, but we are seeing more people attending, and that is something that we want. You'll be aware from previous sessions that we've been quite concerned about the lower attendance at emergency departments and the risks associated with that. We've also seen almost an 8% increase in the level of admissions from our emergency departments to just under 5,000. Again, though, that's 25% lower than the same time last year. In relation to our over 75s, we've seen an increase of over 12% in terms of attendances and nearly 10% in terms of our admissions. So we're seeing that some of our activity, whilst much lower than last year, is starting to go back up. And our trolley situation remains very low, so an average of 20 trolleys per day over the past 7 days. Where we have seen a shift is in relation to our delayed transfers of care, and this is the transfer of people whose care has been completed in the acute setting, and that has gone up in the last week from 215 the previous week to 270. Now that's an indication that people are not flowing out of our acute hospitals as quickly, and that could be linked to the challenges in relation to nursing homes. Many people who would be delayed transfers of care would be waiting to go to nursing homes all of the time, and particularly at this time. In terms of the number of people who are COVID positive in our acute hospitals, we're at 749 as of 8 p.m. last night, with 123 COVID positive people in our ICUs, along with another 150 people in ICU for other reasons. So we had 273 people in our ICUs. Across our acute system, we had over 1,600 beds available, so that's down slightly on the previous week, but we still have 139 ICU beds available. So critically, in terms of ICU beds, we have 411 open and staffed at the minute, with 532 actual beds in place, but we haven't got them all staffed because clearly we still have beds available. In terms of acute hospital capacity, we also have now got the capacity available in the private hospitals, with 17 hospitals signed up to work as part of the health system, or committed to working in the public space, providing an additional 2,000 beds. As of Thursday, we had 130 private consultants who had signed up to work as public consultants, and we are now working closely with the private hospitals through our hospital groups and with the NTPF to ensure that activity is moving across from our public groups to the private hospitals. We know that up to the 17th of April there were over 3,200 procedures carried out in the private hospitals, and we will be building on that intensely over the coming week. Paul has already mentioned the testing that's been taking place in relation to community testing, 47 sites. Last week on the 23rd we had 29 of those open, so they flex depending on the demand in terms of referrals, and they will continue to be a core component of our overall testing strategy. In terms of our clinical assessment hubs, these have been a very significant development, particularly over the past week, where we now have 26 clinical hubs in operation around the country, with 2 more due to open tomorrow. In the past week, we've seen 574 people. And these clinical hubs are multidisciplinary hubs staffed by GPs and other allied health professionals, and they're there to assess people whose conditions may be deteriorating, where they are self-isolating at home. And interestingly, of the 574 seen, 60% of those people went home after being assessed. The other 40% went on to self-isolation facilities or to emergency departments for assessment. So they are providing a pathway for people for further clinical assessment. It's also worth noting that SafetyNet are now proceeding with a mobile and a static hub to support people who are homeless, and that's a very, very significant and important development. In terms of our self-isolation facility, we've had 190 admissions and 102 discharges, so we are seeing people flow through that. And critically, that is, a facility that is taking referrals from all over the country at the minute. We haven't reached the maximum capacity, but it is, accepting all sorts of people for all sorts of different reasons who require self-isolation. Just in terms then, if I move on to the long-term residential care, we know that as of yesterday, we had 425 long-term residential care facilities that were in receipt of support. When we look at the 425 now, we break them down into 3 categories. So of those, 221 were facilities that we feel were stable after some interventions. So we now have a RAG rating that we apply to these centres in terms of green, amber and red, depending on the amount of risk that is associated with them. So 222 are considered to be green, where they are carrying on with minimal support. We have a further 129 who continue to require significant enhanced supports. And I'll talk about the supports in a minute, with 75 in the red category, where we would see that there could be a significant risk in terms of operation. Interestingly, of those 17 are within HSE facilities. When we look at the support that's been provided across the nursing homes, we're providing support to 285 nursing homes. So in terms of the different facilities that we talk about, we have 287 that relate to older persons, but also 82 that relate to disability services, 33 for mental health services and 23 other types of facilities that are addiction and other services. The main support provided, so 303 of those are tele-advice, infection prevention and control support, 283, public health support to 267, and PPE supply to 298. In terms of the support on the staffing front, we know that across our community services, and again, it's important to state that there are many of the HSE nursing homes and community nursing units that are experiencing severe challenges at the minute as well. However, across our community services, we are deploying 119 community staff to private nursing homes. That's as well as many staff being deployed within the HSE to support community hospitals and community nursing units. We have a further approximate 100 acute staff coming from hospital groups, and that would be the boots on the ground staff, as opposed to the specialist support from geriatricians, infection control professionals, physicians, etc., which is significant as well. The other support that we have been working on, and that will come into effect from this week, is the arrangement with the Section 39 home support providers. So we know that from this week we'll be working on approximately 40,000 home support hours being available to support the private nursing homes, and that has been a very significant piece of work that has taken place. In terms of the crisis or the COVID response teams, we now know that we have 23 in operation across our 9 community health organisations, and they comprise of people from, I suppose, consultant, infection prevention and control and other specialist nursing backgrounds. Just in terms of the PPE and nursing homes, this has been a very significant challenge in terms of the provision of PPE to that number of nursing homes. But it's worth noting that over the past week, 60% of all items of PPE that we have supplied have gone to nursing homes. 70% of all deliveries of PPE are to nursing homes. So the extent of the PPE supply to nursing homes is very, very significant. In relation to PPE, we've seen a very significant increase in demand. We're particularly challenged in relation to masks and surgical masks, and we know that we have to up our supply significantly in order to be able to meet the new recommendations around the use of masks. So we have been releasing approximately 200,000 daily, and this will need to go up to 1 million in order to fully implement the new recommendations. So that leaves us in the space of needing about 7 million a week available. So there's very considerable work underway to try and source that number of masks to be able to supply right across the whole health sector, including nursing homes. Just before I conclude, I'm just going to mention a couple of other areas where really there's a very significant amount of work underway that might not be as visible or as, I suppose, aired in the sense of the work that's going on. So across our mental health services, we've been doing a lot of work with the Mental Health Commission in relation to ensuring that people who are detained under the Mental Health Act are having all of their, I suppose, their statutory and legal obligations met. We also have a lot of work underway ensuring that we can continue to provide services across the range of mental health services, from our acute to community services, looking at the use of telehealth and attend anywhere options. Likewise, in terms of our disability services, we have developed a revised model of support to people who are really in the community being supported by families at the minute, where it's potentially very difficult in terms of this prolonged period of containment. So we are looking at how we can support people in a different way, support families, and working with the regulator in terms of the need to establish any temporary emergency residential accommodation. We're also working across our system in terms of providing staff at a psychosocial level to, I suppose, to many staff who are encountering high levels, I suppose, of deaths in terms of our nursing homes, long-term residential care facilities. We know that people are very, very, I suppose, stressed in terms of working in those environments. It's very challenging, and we are now putting in place a range of supports for staff working across the full health system. And that's something that's very important for us, because we know that this has been a challenging time to all of our staff. And just to reiterate what Paul has said, just to thank all of our staff who really have been working in an extraordinary way and working in very difficult circumstances. So it is our absolute intention to roll out that support to everybody over the coming weeks. Just in terms of support to staff, it's also worth mentioning that we've had a very significant increase in the uptake on staff accommodation over the past week. So for the past week, we've had 1,050 people approved for temporary accommodation, and interestingly, of that 1,050, 605 of those people are from the private nursing home sector. So we have been providing accommodation, with a very significant amount of that on the north side of Dublin, and in all cases, whether it's to do with hospitals, nursing homes, homes or anything else we're talking about, we can see that the bulk of our activity continues to be in the Greater Dublin area. So I'm not going to keep talking anymore, and we're happy to take questions afterwards. Thank you.
Okay, so thanks, Paul, and thanks, Anne, for that. A lot of information there. I'm sure we'll touch on some of this information as we go through the Q&A session. We have 6 journalists here in the room from different organisations, and what I intend to do is, if you can raise your hands if you want to come in on questions. We have a roving mic with a suitably social distance, so we can take your questions. We'll try and limit the questions so that everybody can get in on the questions that they want to ask. So we're happy to go back around again if you've got further questions. Okay, Nicole. Just wait for the mic. And can you introduce yourself as well, please, and the organisation you represent?
Nicole Gernon from Virgin Media News. I just have some questions in relation to nursing homes, first of all. So just in terms of, you mentioned there on the number of staff that have been redeployed to private nursing homes, but do you have the total number of staff that have been deployed to all nursing homes, private and HSE related? And also just in relation to St Mary's in the Phoenix Park, how many cases are there of COVID-19 in St Mary's at the moment, do we know, and how many people there have died with either COVID-19 or presumed COVID-19?
Okay, so staff
so
first.
I'll take the staff piece, and I might ask Siobhan to comment on St Mary's. In terms of the staff, so I don't actually have a number for all of the redeployment. What happens in relation to the HSE facilities is we literally deploy people on a continuous basis, so we don't count them in the same way, and that's a challenge for us in terms of how we count the staff deployed to public or private, because we literally send people. So we have some situations, for example, in relation to the acute hospital support, where acute groups have effectively taken over the running, more or less, of a nursing home. However, in relation to the HSE facilities, we deploy a lot of our community, so primary care staff, and that they move in and out. So depending on the day, there might be a particular challenge in terms of filling shifts, rosters, etc. So I don't have a number for the HSE when we just try and cover those as we go. 119 community staff have gone into private nursing homes, and that's over and above the support that we provide to the HSE facilities.
Just a brief point to that, because I don't think we do justice by just a single number. Some of the nursing homes, as you'll see, and Anne has mentioned, the likes of Louth, where we've practically taken over the oversight and running, and then the multidisciplinary teams are operating in and out of on a regular basis. If we were to calculate the total resource committed to private nursing homes, it would be very significant. I don't have a number on that, but I don't think we're doing justice by one single number, because the resource, the commitment, as Anna said, in terms of private nursing homes, it's the priority of all our PPE distributions. It's been the priority in resourcing, it's been the priority of our testing, and it's been the priority in terms of accommodation. Okay,
in relation to St Mary's, Anne or Siobhan,
So I think what it's very important to emphasise is, the huge impact, obviously, that COVID-19 is having in many of our facilities, as Anne has said, and obviously St Mary's being one of them. Sincere sympathies, I think, firstly to all of the residents and families who have been affected in a very direct way by this outbreak as a result of what's happening there. And we also have a number of colleagues, some of whom we all here work very closely with, who've been affected directly by that outbreak as well. So it's important to remember the impact that this is actually having in a very kind of real way. Part of the difficulty with the numbers that you're looking for is actually around the breakdown that between staff and residents as it's actually happening, and obviously the extensive testing exercise that was done this week will probably give more information, so we'll be able to give a more updated picture, I think, around that in St Mary's later on in the week. Clearly there have been a number of fatalities. You'll have seen the public press reports around the 20 cases that have happened between April. What I don't have is a fuller picture in terms of what may have preceded that. But we will be able to share those with you as those numbers become available to us. So in all of these facilities. We have people who have died as a result of COVID-19 disease that has been confirmed, for example, by testing before the person would have passed on. But equally, there are those who would have passed on with suspected symptoms, and some of the testing will be coming back to us from that. So we will have a fuller picture around what the impact in some of our HSE facilities looks like, hopefully towards the end of the week, and we'll be able to share that with you then.
Okay, where are we going next? Okay, Orla.
Hi, Orla O'Donnell from RTE News. I've just 3 questions. First of all, for Paul Reid, what concerns did you express to the Department of Health about the rollout of testing and scaling it up to 100,000 tests a week? Also, if you could tell us more about the app, the contact tracing app, and when that's going to be rolled out. And finally, just in relation to nursing homes, I think you said there were 75 nursing homes which had a red light attached to them. They were severely at risk. What's the status of those nursing homes? What's happening in those at the moment if they're so badly at risk and things are so bad in them? What effect is that having on residents, families and staff?
Yeah, just on the testing and tracing, just say a few points. First of all, when I took up this role over less than a year ago, I would be naive in the extreme to think that there would never be tensions between the HSE and the Department of Health, and they are very constructive tensions. But just to make a second point, I think what we've achieved during COVID-19, working together, has been phenomenal, and something I'm actually very proud of, how we've jointly worked on it. Specifically related to testing and tracing, the key issues for us were, from the HSE perspective, were what's the roadmap that gets us to 100,000? Because, as I described in my introductions there, this has been a war zone model built, and we now need to have something more sustainable. So we've had to carry out, my concerns were that we carry out a detailed process review of the whole end-to-end process. Where can we maximise efficiencies in terms of turnaround, and how can we scale up the labs to sufficient capacity? We've made very good progress in the last couple of weeks in particular, by bringing on more labs, and the NBRL now getting up to 5,000 a day, and also our German labs provision. So clearly the concerns were in terms of timing to get to 100,000, timing to put in place the initiatives that we have to put in place to get us to that. I'm very pleased to say over the last week, based on our discussions around those concerns, we've put together a shared paper which will go forward to the Cabinet next week, and I'll be happy to brief you later next week on it. But it is an agreed paper now between ourselves and the Department of Health senior officials, Secretary General. So we now have a shared roadmap. And a shared roadmap how we get there, and how we align the case definitions to support us getting there, which has started this week already. So in a much better place, I have to say. On the app, like any app, there's a few aspects to this that we have to work through very carefully. One is the engagement and dialogue with the Data Protection Commissioner, and that's a process that's ongoing, just to work through any concerns related to that. Obviously, the second issue is the integration between whether it's iOS and Android phones and systems and how they work, and also the Bluetooth technology. Our expectation is in May we will be in a position to launch a pilot of it. It is one that's proving beneficial across Europe, so we're hopeful to be in a position in May to launch a pilot of it. It's good progress, but like everything else in terms of software and user acceptance testing, you take one step forward, and we want to make sure that this is reasonably resilient over the next couple of weeks.
Okay, in terms of the nursing home, Anne?
So I think I mentioned the 75. For us, what that would indicate is that they are particularly challenged, for example, in relation to having just enough staff. That would be a key thing, and they would be the sites where we will have deployed the highest numbers of staff. As I said, there are 17 within that mix that are HSE facilities. For us, though, I think it's inevitable as the testing rolls out across the nursing homes, we will see more outbreaks identified, inevitably. And for us, the challenge is really to be able to identify the nursing homes that have a critical need for a high level of support. As I said, we have 221 of the 425 that are actually doing okay on the foot of some intervention. But there are many nursing homes that are just relying on telephone advice and support, or maybe infection prevention and control support. But that 75 would be the key area for us to focus on in terms of intensive supports. For example, the nursing homes where we've deployed significant numbers of staff from the nearby hospital group or from the local community services.
Okay, Orla, you happy enough with that?
Yes.
just go back in there. Yeah.
Just on that, does it mean that residents are being moved out of them, or no?
No. I think, our preference, and we have said this consistently, is to ensure that we can support the nursing home to continue to provide care. I know we've previously had discussions, and Siobhan might want to add to this in terms of just the concept of moving people. But it is very important that we seek to support the nursing home to provide care, because ultimately the nursing home is the person's home, and they should only be moved on the basis of clinical need, where there's an actual clinical opinion taken that they need to be moved to a different facility.
Siobhan?
Yes, I mean, many of us clinically have been very involved with managing these outbreaks on the ground, with GPs, with geriatricians, and other, specialist colleagues who are offering support in a very real-time way to supporting many of the residents that are being managed by our skilled nursing staff in those facilities. Orla, I think the point for us actually is that we are seeing that patients are actually being well managed and well cared for. As Anne has emphasised, it is around ensuring that we can, as much as possible, shore up that support and care that's actually needed within the resident's home itself. Most of these patients are actually managed well with good attention to detail in terms of fundamental nursing care, like ensuring that they're having adequate fluids, adequate nutrition, and that they're being minded appropriately from that point of view. There are another group of sicker patients who need higher level nursing support, and again, a lot of our nursing colleagues who are shoring this up in the units are making sure that that's actually being provided as well through geriatrician support, through palliative care support, and others.
Okay, Juno, you're trying to come in now. Just wait for the mic.
Just two questions for the panel, please. The first...
Just introduce yourself, Juno, please.
Sorry, Juno McEnroe with the Irish Examiner. The first is in relation to nursing homes again. There are some reports that the moving of patients out of hospitals into nursing homes has in part triggered a spike in the spread of the virus among long-term facilities like that. Can you comment on that and maybe give us an insight? And the second thing is just to go to the issue of the easing of restrictions, and we're expecting some discussion on that this week from a cohort of different areas. What are your thoughts on those, and what kind of precautions should be taken if we move into an area where we start easing those restrictions?
We'll start with the second one first, Paul.
Yeah, thanks, Juno. Just as I say, every week the decisions around restrictions are ultimately for government, and recommendations emerge from there from NEFIT, so I never stray into that line. But just from our perspective, as I mentioned at the start, a couple of things. The running of the health system, the HSE, as people emerge back, hopefully and thankfully, and foster a wide range of services, we'll have to put wider protections in, not just for COVID-related patients and wards, but across the whole hospital community, social care system, working with our agencies. So we're going to have this kind of parallel system operating that's going to have to, keep diligence across not just COVID-related issues, but also across the wider services. And obviously, from our own perspective, is to reiterate the call to the public just to stick with us as we go through this process. I'm very conscious that, look, when we talk about complacency and we talk about compliance, that's good and that's what we need. But we need to win people's hearts and minds as well in this process. So it really is winning people's hearts and minds with us along the way to understand what we're trying to do, to understand the benefit of what they have done, and it's made such a big difference. So, I'd be talking about winning their hearts and minds in a couple of weeks, in the next few weeks as well, as just talking about compliance.
Okay, and then the piece in relation to moving long-term residents into nursing homes.
Moving residents or moving people from acute hospital into nursing homes, I think is what you were asking me about. So actually there's no evidence really to kind of support that assertion that that virus was transmitted in that way. That's clearly something we're going to have to look at. I just want to bring you back to where we were at the end of February when we actually had our first case, when we were looking at what was happening in Italy and Spain, where the outbreak was very much focused in terms of what was happening in acute hospitals there. ICUs overflowing, acute hospitals overflowing, and it became very clear to us that within the capacity that needed to be created within our acute hospital system, that we needed to identify firstly those patients who were stable and medically well and could be moved as a matter of priority. Many of those did move into residential care. It was done through appropriate protocols that were actually put in place to support their safe transfer. I think the other thing that was very clear to us within the context of that pandemic as it was emerging in those countries was that the risk that would be posed to people who had completed their acute treatment, who would have finished their hospitalisation ordinarily and were actually waiting to go to long-term care facilities, that they would not become exposed to COVID-19 virus within the acute hospital. So all of those decisions were very much taken with, as Paul would have said, on a war footing around actually creating that immediate need for capacity for what we felt was an emerging community outbreak that was going to significantly affect our acute hospitals in that regard. I think it is fair to say that we are going to have to learn through the exercise that's happening around testing at the moment in our acute hospitals, in our residential care facilities, around what this pandemic looks like in those facilities. We're learning literally as the pandemic emerges around what is actually happening, what actually causes most transmission. Is it staff transmission? Is it resident transmission? Or how does it actually look? And the exercise that we're actually taking on board in terms of the mass testing that's happening in residential care facilities will give us a much better view as to what it is that makes those facilities so much more vulnerable. And so we've actually been to the forefront of many European countries in taking this approach. It is going to have a significant impact in terms of detecting high levels of people in those facilities who do not have symptoms, and how that is going to be managed out is going to prove its own challenges over the coming days from that point of view.
Happy enough, Juno? Yep. Okay, Priscilla's trying to come in there.
Priscilla Lynch, Medical Independent. Can you just tell us currently how many nursing homes are affected? I know last week it was about 40%, and how the testing exercise is going and when it will be finished. And just following on from Juno's question, do we have a policy in place now to test patients that are going from hospitals into long-term residential facilities? And are they being given a choice not to go into a home that currently has an outbreak of COVID-19? Because in the UK that's been a big factor in relation to the spread in nursing homes there.
Okay, we'll start with the third question. Paul, do you want to take that? Or on the testing leaving?
Yeah. Just on the testing over last week, our priority has been in long-term care locations and primarily nursing homes. We've swab tested in total between our community testing as well, 37,000 swab tests last week. 20,000 of those were either patients and residents in long-term care locations. So that's been our primary focus. So that will continue over the next couple of weeks. Where we'll continue to test people. Primarily our focus has been on, as I mentioned last week, firstly where we have had outbreaks, patients, residents and staff. Secondly, where outbreaks have emerged over the past week or so, and next week we'll continue to do it. And thirdly, our priority is staffing and residents in nursing homes. They're the ways we're working through the list right now.
If I'm correct, your question was, are we going to swab patients leaving hospitals going back into nursing homes?
I'll leave that to Siobhan.
Okay. Siobhan, do you want to pick that up?
So there are protocols in place. They're on the HPSC website, and they very specifically refer to the testing of patients where that's clinically indicated, Priscilla. Obviously, a huge amount of what's going on here has been around, for example, broadening the case definition of what COVID-19 looks like in older and more vulnerable populations. We started off in a place 6 weeks ago where COVID-19 looked like it was primarily fever and cough. We're in a very different place now. We're actually going to be in a very different place by the time our testing across all these facilities are finished in terms of understanding what COVID-19 with no symptoms looks like and the impact that may or may not be having, as I've alluded to previously. So it's going to change and challenge us a lot in terms of how that care provision actually is dealt with and how it's provided, how we manage that situation so that, as Anne has alluded to, we can continue to support people moving from acute hospitals into long-term care when they have finished their acute